of the leak. Whether it is coming from the cruciform plate, whether it is coming from the olfactory bulb area, because that is the weakest area. Another place is persistent Sternbach's canal. There are various other causes like obesity, osteoporosis, persistent Sternbach's canal, idiopathic raised intracranial tension with empty sella syndrome. These are rare causes, but one must keep in mind that this could also lead to spontaneous CSF leak. Now, how does this CSF leak patient present to us? So most of them come with a watery nasal discharge. Patient comes and says that doctor clear fluid नाक से आ रहा है, बहुत पानी टपक रहा है. There can be persistent colds. Some of the patient may not understand whether it is a CSF leak or it is a common cold, and they are getting runny nose. That too also unilateral. Patient can have balance abnormalities. They can come with the symptoms of meningitis, or they can come with other neuronal symptoms. So, there are two things. When we examine this patient, we have to see for the teapot spire sign and for the reservoir sign. So, what is the teapot sign and what is the reservoir sign? So, I will show you. What is that? Again, the video is not seen. Please be audible with your guys. The videos are not seen. This is how patient presents with the teapot sign. When we give our test tube to the patient and the patient bends, you can see the CSF leaking and the patient is collecting into the test. And it comes drop by drop. And then we come to the reservoir sign. When the patient bends like this, we can see that the CSF is gushing. Now, how will we assess these patients? So whenever we want to assess this patient, very, very important, we just now will see that we have taken a proper history, like with what complaints the patient has come to you. Then the clinical examination is very, very necessary. And after examination, we need to find out whether it is CSF leak only or it is plain rhinitis. So first we confirm our diagnosis by various investigations and tests. Then second aim of our treatment is we will localize the site of the defect. In which area? Medial lamella, lateral lamella, sphenoid sign, from where the leak is coming. Third is assessing the size of the defect. Whether it is a small defect, it is a large defect. Because all these things matter in the management of the CSF leak. Selecting the appropriate surgical approach is equally important. So once we assess the site of the leak and the cause, and depending on that, then we will go for the surgical correction of the CSF leak. Now, the most important test in this or investigation is beta-2 transferrin. We will see whether it is positive or not. Second is CT cysternography. CT cysternography will let us know what is the site of the leak, exactly from where the CSF is leaking. And then sometimes we may have to go for HRCT temporal bone, and according to the investigation reports, then we will proceed for the surgery. Now, this is a flow chart which will show us that when the patient comes with the confirmed CSF leak, when the beta-2-transferrin test is positive and we know that it is CSF only and it is not plain randomly, what we would do is that we would like to rule out the intracranial pathologies. And the patients with intracranial pathologies, if they have any intracranial neurological problems, we will refer them to neurosurgeons. But if they do not have the intracranial pathologies, then as an ENT surgeon, we will have to treat this patient. So first we will find out whether it is a spontaneous leak or it is a post-traumatic leak. If we have a post-traumatic leak, what we do is that we need to treat them conservatively. So maybe for 2 to 3 weeks, we can give the conservative management, and usually the leak stops when the fibrosis occurs. But if you have spontaneous leak, in that case, surgical repair is must. There we should not wait frontal defect or the defect is present from plate, root of the roof of the sphenoid or moist. What we do is that we have to go for endoscopy repair of the CSF sinus. But if we have the defect into the frontal sinus area, and sometimes if coming from the posterior level of the frontal sinus, then it is very difficult for the ENT surgeons to treat that case. So in that scenario, the patient will have again to go for the open approach or the neurological approach where the bicoronal flap is taken, the frontal lobe is retracted, and then from above the graft is placed. So that is a major procedure, and we need to explain the patient that they have to undergo this type of management. So beta-2-transferrin test, it's a qualitative test, and it is a highly specific and sensitive test, which is a non-invasive method in identifying the nasal fluids and CSF. However, beta-trace protein quantitative assay has specified of nearly 100%, but it is more expensive test, so every patient cannot afford it. So let's come to the surgical management of this type of cases. So as I told you, first we find out the site of the leak, so from where the leak is coming, and it is leak only. Then expose and delineate the defect with a bipolar cautery. We can see whether it is a meningocele coming out through the defect or not. Then we have to create a raw area surrounding this defect. Plug the defect with fat, fascia or surface. Every defect need not be plugged with the fat. Some of the defects can be only closed with the fascia. So the large defect, like if we have a large defect and where the brain is exposed, or you can see the dura exposed, in those cases only fat plugging and tensor fascia lata fat is not fascia is not going to help the patient. So in those cases you require a sturdy repair. So in those cases we may have to harvest the conchal or septic cartilage, and we will have to close in 4 layers. And tissue glue is must. Now I'll give you the recent example. Like 2 weeks ago, someone had called me in a private nursing home setup to do the CSF leak closure, and unfortunately the glue was not available. So we closed the defect, and after 2 days again the patient had the same problem. So tissue glue is must, because especially in cases of high pressure leaks, if we have a low pressure leak, at least it heals. But if you have a high pressure leak, you have to have tissue glue, and without that the patient will not really recover. So that is one message I wanted to give. So no compromise in getting the tissue glue, and then it has to be covered with the gel foam, and then we can finally put the Merocil. Now the method of putting Merocil also, like we have to put Merocil supporting, like how we support the roof with the pillar. Like that we'll have to support with one Merocil the closure what we have done at the roof. One Merocil will go perpendicular like that, supporting the assembly, and then the second will go into the along the floor of the rooms. So this has to be done carefully, and whenever we are doing this, so while doing that, we are not supposed to displace whatever graft or fat we have placed at the side of the defect. So there are a few cases which I would like to explain here. Now this is a 54-year male patient who came with the bilateral CSF rhinorrhea, and we can see that his BMI was very low, and we can see the bilateral cribriform plate leak. So there is a bath plug technique with which we can seal this. So this is how the defect was seen like, and I would like to explain the bath plug technique. What we can do is that we can take a, from the thigh, the lateral aspect, we can take a chunk of fat, we have to take a little extra fat. We can suture into the suture material, and at the end should be tried. And then we can put that bath plug inside, and we have to see to it that it is snugly fitting inside the defect. It has to go and fit snugly fitting inside the defect. And once we put that inside, and we think that now we are done, slightly we'll have to pull the thread out. So don't cut the thread immediately. And when you are pulling the thread out, and if the fat is not coming out and we can get that sensation of snugly fitting fat, that is a time when we can cut the face. And then we can apply the gel form like this. Another patient, 60-year-old female patient, came with the right-sided watery rhinorrhea, and the CT cystoscopy was done, and as we can see here, you can see the defect here into the medial lamina. So sometimes, in medial laminar defect, we do not even go for fresh surgery. None of the videos are playing, anyways, I'll minimize the show. So the message here is that whenever we have a medial laminar leak, it is better to trim the middle turbinate. We trim the middle turbinate, we find out the site of the defect, and we close it with the tensor fasciolata. Usually the medial laminar leaks, if they are smaller ones, they do not require the bath plug technique. Only tensor fasciolata can take care of the defect. And if we want, like this, we put a tensor fasciolata graft. Above that, if you want, you can put one more layer of fat, and then you can put a tissue glue, and you can put a gel foam above that. But we have to see to it that the graft is little bigger as compared to the size of the leak. And then this is how the tissue glue has to be placed. Once we put the tissue glue, wait for some time. Because sometimes what happens when we do immediate suctioning, the entire assembly will come out. So it is better not to touch it immediately. Let the gel tissue glue set it, and then we have to do the remaining part. This is how the white color has to come, like this. This is how the tissue glue has set now. And then after that only any instrumentation should be done at the site of the leak. And then we can put a extra layer of fat if we want, and we can put a gel. So sometimes it is so difficult that we may not be able to see the site properly. Like everywhere we feel that it is leaking and it is a CAC leak only coming. Then in those tricky cases, sometimes navigation plays a very good role. If someone has a navigation system, it plays a wonderful role to detect the site of the leak, and exact site can be seen. So as I was telling that if you have a very big defect, and if you want to go for 4-layer closure, then the cartilage may have to be required, and we will have to go for the cartilage. Harvest the cartilage from the septic cartilage from the same site, or we can take the cartilage from the buccal cartilage also, if the septic cartilage is very thin. And we have to take appropriate size of the cartilage. It has to fit in the way I have shown. It has to fit in. First you can put a bath plug, then you can put a cartilage. It has to fit in completely. Then you have to put a third layer of tensor fascia data followed by gel film. So many a times there is a googly, like we have googlies in the cricket match. So this is a case who presented with the secretory otitis media, and when we saw the impedance audiometry, it was a B type of curve. So we did not know how the patient was getting this, and patient had persistent symptoms of, and it was not relieving with whatever unrealized glucolytic drugs we were giving to the patient. And we found that this patient had Beckel's cave arytenoid cyst, and because of that, it was leaking, and through the eustachian tube, the CSF was getting collected into the media. So here now, we don't have to treat the patient will be treated by the neurosurgeons. Another patient had Sternberg's canal, and there was a CSF leak which was coming constantly. Another patient we had, sometimes we see the meningocele. So I'll show you a small video of the CSF leak. So that's a very beautiful meningocele which we could see, and this type of CSF leak is very beautiful, and we can see the exact site of the leak. And these type of meningocele, first what we will have to do is that in this case now, we will have to, at the base, we will have to go and bipolarize. We will have to do the bipolar quarterly, and after that, we can seal the leak. So our work was presented and got published into the International British Journal. This is we have done a lot of cases of spontaneous CSF leak and concentrated on spontaneous CSF leak. Coming to the conclusion, when we want to obtain an accurate history, it is a crucial first step for the perfect management of the CSF rhinorrhea cases. Etiopathogenesis for the spontaneous CSF leak is multifunctional, and hence it is very necessary to find out the etiology. Understanding the pathophysiology is utmost important for management of planning. Now here in this case, along with that, when you have low BMR, high increased body weight, vitamin D deficiency, so we need to tackle all these other medical themes also in addition to doing the surgical treatment. Definitely, but also the treating etiological factors to prevent the recurrence. Suppose if we treat a spontaneous CSF leak and we do not take care of the medical management, then the patient will definitely come. I have also seen that one side we have seen, and after some days or months, the patient has come immediately, just surrounding area, it is leaking now. So whenever they have high pressure, one side is closed, next side opens. So that is why we need to take care of all the other etiological factors also. And tensor fascial data and septic cartilages are excellent graft materials because we do not have to take any extra incisions. And as I showed you, 2-3 googly cases where it was appearing secretory otitis media and the cause was not seen, CSF, cystostonography was normal. So if we want to provide an umbrella so that we get rid of the rains, similarly, if we want to give a good umbrella to the patient of CSF rhinorrhea, we must do a proper surgical repair with a proper medical management. Thank you.
Any questions from the house?
What is the ideal duration of treatment, medical treatment you provide after the surgical?
Question allow me a question.
So allowed है कि नहीं question?
बताइए हमें कि आप क्या पूछ रहे हो भाई?
Yes.